morning, everyone. And today I'm speaking about allergy and keratoconus. The statistics is that it affects about 15% of population. And by some account, that means 50 million Americans suffer from some sort of allergy, and the incidence seems to be rising. It could be because of increased awareness, it could be changing environment, but we're not exactly sure why. It is sixth leading cause of chronic illness in the United States, believe it or not, and estimated cost to the healthcare system is that of over $18 billion a year. And we categorize allergy in this basic ways, a major allergy to include things like hay fever, to include asthma and atopic dermatitis. These tend to be more chronic, and the minor allergies are things like itching, food allergies, and they tend to be more intermittent and depends on exposure. And when doctors and scientists look at allergy, we kind of look at what happens at a cellular level at the immune system, and it requires exposure to allergen, and the cells in your immune system reacts to it. Okay, and one of those mechanisms we call type 1 hypersensitivity, and an example of that is a poison ivy, for example. And so if you're exposed to poison ivy, you start getting rash and swelling and itching and sometimes worse. And the way the body recognizes the poison ivy is that the first time you're exposed to it, it creates these cells called mast cells. And mast cells are circulating around to begin with, but it'll prime itself with a particular kind of antibodies. So the second time you're exposed to the poison ivy, then the mast cells discharges. So that releases histamines. And the histamines are what causes the itching, the redness, the inflammation. And so that's why when you have allergies, you take antihistamine. That is to counter the effect of histamines. And for type 1 hypersensitivity, it takes 2 exposures. So the first time you were exposed to a poison ivy, you don't have reaction, you don't have the histamine reaction, but the body is primed. And the second time and the third time and every subsequent time, then the histamine comes out. And histamine results in symptoms of allergy and ocular allergies. And in the eye, it's basically it's inflammation and the itching, and also tearing and the redness. Histamine then stimulates your immune system to recruit more inflammatory cells, and some of these cells actually causes damage on the eye. The other aspect of ocular allergy is what we call type 4 hypersensitivity. This is more like a deeper memory in your immune system, and these can be long-term and they can be persistent. And some people develop this, and we don't exactly know how or why, but some of the possible mechanism is ongoing research topics among doctors who deal with inflammatory diseases. The itching is the hallmark of ocular allergy. So if somebody who has irritation of the eye, and if it doesn't come with the itching, it probably is an allergy. But if there's itching, then it probably is allergy. And the eye rubbing is a natural reflex of allergic eye disease. And in addition to itching, there could be tearing, there could be redness, irritation. The eyelid can appear thickened from the inflammation as well as the eye rubbing, which also causes inflammation, and also mucoid discharge that's kind of stringy, okay? And the manifestation of ocular allergy outside of the eye is sneezing, congestion, runny nose, and the dermatitis and the rash on the skin around the eye. This is all in response to the local inflammation. And the eye surface actually is connected to the nose. There's a passage where inflammation can travel through that into the nose. So people who have runny nose chronically from allergy, if you put eye drops, like antihistamine eye drop, in fact, the runny nose gets better. In the eye, allergy condition, we divide it in this way. We have allergic conjunctivitis, and there's a vernal keratoconjunctivitis. There's something called giant papillary conjunctivitis, people who with the contact lens use get, and something called atopic keratoconjunctivitis. And specifically vernal and atopic, these are clearly associated with keratoconus. Most common form of ocular allergy is that of allergic conjunctivitis. Many of us suffer from it. I suffer from it on occasion. And there are two kinds, seasonal and perennial. Seasonal means you're allergic to some pollen or of grass, of trees, maple, whatnot. And it's fairly specific, different from person to person, ragweeds. And usually lasts when those pollens in the air, usually a week or two at a time, a year. And people who are allergic to dust or animal dander, they have perennial allergies. It's around all the time because your pet is around you all the time. And it could be to dust and dust mites and sometimes mold. When you have allergic conjunctivitis, they're itching. There's burning, there's watery mucoid discharge, and you're usually bilateral because allergen is usually exposing both eyes, both eyes exposed to the allergen. And the eye's inflamed, and the conjunctiva, the covering on the eyeball, can be swollen, and we call that chemosis. And they can be papillary conjunctivitis as a result of allergic conjunctivitis. And people with the chronic allergy, they have like a little crease on their nose because they're doing this all the time. And they can also have like a little shiner on the eye. It looks a little swollen because they're rubbing their eye all the time. And this one we call it allergic salute. I don't know who said that, but it's in some of the textbooks. And some of the things we look for in the clinic when we see patients. Vernal keratoconjunctivitis is a chronic bilateral conjunctivitis that affects mostly boys, generally age of between 10 and around 10, before 10, and lasts about 2 to 10 years, and usually resolves after puberty. And there's a history of eczema or asthma in about 75% of these patients. So it's a kind of major allergic syndrome. And there's a seasonal flare, but they have problem around the year. And what they have is a lot of itching. These kids are rubbing their eyes all the time. And there's excessive tearing, there's ropey mucus production, and they're generally sensitive to light, so they tend to kind of shy away from playing outside. They're burning, and they may feel scratchy, and there may be pain. It's more common in the Mediterranean areas and the Middle East and West Africa. So there's some sort of genetic predilection. And it's also documented clearly in the literature to be associated with keratoconus. In the eyelid and the skin margin, generally is not affected. But if you flip the eyelid, you see these what looks like cobblestone, what we call giant papillae. And they may also have bumps along the edge of the cornea, we call limbo nodules or Trantus dots. And they're rubbing their eyes chronically. And over long term, they may develop blood vessels in the cornea, we call pannus, and there may be inflammation in the cornea because these bumps, when they're on the eye, it rubs up against the cornea. So the area with the inflammation in the conjunctiva then transfer to what is touching, which is the corneal surface, and the surface can break down, and this is what we call corneal ulcers, and this could be a sight-threatening condition, as these can alter the shape of the cornea. Not only that, sometimes it melts through, and then there's a hole in the eye, which becomes an emergency. And Vernal Keratoconjunctivitis is type 1 and type 4 hypersensitivity, and it's an autoimmune disease, okay? And I told you that there's a racial predilection with the genetic predisposition. GPC, or the giant papillary conjunctivitis, is a large papillae associated with itching, conjunctival injection, or inflammation in people who have contact lens or other foreign body that's rubbing on the conjunctiva chronically. And other meaning some people have sutures on their conjunctiva from surgery or whatnot, and they can get these kind of cobblestone-like condition similar to vernal, but this is clearly caused by like some sort of foreign body. And then usually by removing the foreign body, whether it's the suture or contact lens, generally this resolves. And atopic keratoconjunctivitis is a chronic condition, again, that is very similar to vernal, except it affects adults, and mostly males, but it could be men or women. But they have, in addition to the eye problem, they have a skin problem. The skin has like kind of thickened appearance to it, where the vernal doesn't, and they have, in extreme cases, their eyelashes are lost, and like you can see in this patient, the lid is very much thickened and has this matting of mucus all around it. And there'll be early signs are just some mild discoloration, but these patients are rubbing their eyes constantly also. And there's also scarring of the conjunctiva, we call symblepharon, in these patients. They also get keratitis like vernal, but generally it's much more severe. And it persists, and if it persists and becomes scratches like a corneal ulcer, it can scar like this. And this is sometimes complicated by herpes infection on top of it. There's corneal neovascularization, meaning blood vessels forming in the cornea, and this cornea can be thin, and they can perforate, and again, that becomes an emergency. It's associated with keratoconus for sure. Okay, this is over and over in literature. It's been documented, and this patient has severe atopic dermatitis and keratoconjunctivitis, and as a result, she had keratoconus, and she had multiple transplants before she came to see me. But her cornea keep failing, and eventually she had a complication from glaucoma and basically lost most of her sights. And patients with atopic keratoconjunctivitis also have higher incidence of retinal detachment, probably because of eye rubbing. And they get a certain kind of cataract called posterior subcapsular cataract, and they generally have poor outcome with corneal transplantation, as documented in this patient's case. But you gotta understand, this is because frequently these cases go without having the atopic disease being controlled. You got to control this first, then do the corneal transplant. Then you have a better outcome. Ocular allergy and keratoconus, as I mentioned, there's a clear association in the literature, and as I took the survey at the beginning of the talk, I said about 20 to 30% of the room seems like to have raised their hand, and I know some people didn't. I usually don't raise hands in these room survey anyway, so there's probably even more. So I said 15% of Americans are affected by allergy, but in this room there seems to be more. There's some patients in here. Could that skew our informal survey? That's what I'm thinking. And with the allergic eye disease, the implication is that first, patient becomes less tolerant to contact lens use when you have allergies. Okay, besides the GPC, when you have allergy, it's very hard to wear contact lens, and the GPC can limit the duration of contact lens wear as well. Ocular allergies are, like I said, associated keratoconus, and we think that all these inflammatory diseases, there's activation of enzymes in the body, on the eye surface, that actually chews away the collagen in the cornea. This is a little harder to prove, and how that leads to keratoconus, where it's shaped in a certain way. The thinning is only certain area of the cornea, but it's certainly a plausible suggestion. And there's also chronic eye rubbing is associated with keratoconus, independent of the fact that it's related to allergy. So in statistical analysis, just rubbing eyes alone is a major predictor of keratoconus. So in other words, patients with Tourette's syndrome, they don't have allergies, but they may have tics, meaning that they can't stop rubbing their eye. And these patients do get keratoconus, and it's the eye that they rub. Okay? So it's not an inflammatory condition, but the eye rubbing seems to be associated with keratoconus. There are case reports and series suggesting 50% or more patients with keratoconus have some sort of allergies. Okay? And the recurrence of keratoconus has also been noted in patients who had undergone corneal transplant. Following corneal transplant, the cornea is normal thickness, normal shape, and over time, if you let that person be, this particular case report is somebody who had allergy and a chronic eye rubbing, okay? And the keratoconus came back on a new cornea. Some of the proposed mechanism how eye rubbing leads to keratoconus includes increased cornea temperature may lead to less stable collagen fibril in the corneal tissue, and they may allow the cornea fibrils to slip and become looser. Okay? Mechanical stress, if you take a piece of like a rubber and then keep rubbing on it to flex it, it'll denature the connection and may lead to potentially a weakening of the tissue. And then same thing with the corneal tissue and then keratoconus in eye rubbing. There's also increased intraocular pressure, suggestion that may lead to stress in the cornea, resulting in a weaker collagen fibril. An example of this is patients with the glaucoma, especially patients like a congenital glaucoma, kids who are born with glaucoma. Their pressure in the eye is constantly high, and this leads to thinner corneas, and their eyes are larger and the cornea is stretched out and thinned out. So if you rub your eye constantly, you're actually effectively increasing the pressure in the eye, because the pressure of the eye is determining the volume and what's in it. So if you decrease the volume by pushing on it, you have less volume but the same content, so the pressure is higher. Okay? Can that then lead to development of keratoconus? These are some of the suggested possible mechanism of why keratoconus allergy and eye rubbing leads to keratoconus. So if you have allergy and rub your eyes, it can potentially lead to keratoconus. And to successfully treat keratoconus, I try to, when the patients comes to me with allergy who have keratoconus, I always inform them that allergy needs to be controlled. Whatever it takes, work with allergists, allergy shots, medications. It's one of the key components, in my opinion. You should avoid eye rubbing, as this may prevent progression of keratoconus. Cornea transplant, as we know, is more successful in patients with things like atopic dermatitis and keratoconus when their atopic disease is better controlled. This is an example of a 50-year-old man who came to me with horrible allergy of his face. And he's had contact lens, but were too uncomfortable to wear because of his allergy. It was because of his atopic disease. And he takes Zyrtex daily for his allergy, but it was just under controlled. Not under control, it was inadequately controlled. And his vision was 2400 in the right eye, 20/30, and the cornea was already thinning in the right eye. He was chronically rubbing his eye, and his eyes were always red. His eyelids were markedly thickened, and so I made a diagnosis of atopic dermatitis and keratoconjunctivitis. There's an inferior steepening of the cornea, much like early keratoconus. So we started him on oral methotrexate, and his skin responded very well. It cleared up, mostly 90%, and he was very happy just for that. Then we performed cornea transplant in his right eye, and 6 years later, his vision remains well. His cornea remains clear. His vision in the right eye is 20/30 with glasses. Left eye is 20/20. He didn't even need a contact lens. He was wearing contact lens, hard contact lens, before he came to see me. And the skin condition remains under control with methotrexate. This is his topography last year. Much better shaped. There's still a little inferior steepening here in the left eye, but overall he's doing much better. So in summary, ocular allergy is a common condition, and ocular allergy affects keratoconus patients by reducing contact lens intolerance in the GPC form, and keratoconus may be in part caused or worsens by ocular allergy and eye rubbing. And control of ocular allergy may improve treatment success and the surgical outcome of keratoconus. Thank you.